As already mentioned, it's possible to decompress, transpose, and even suture any nerve using the endoscopic technology we have developed, since the plane of introduction of the retractor blade is located above the course of the nerve. Tarsal tunnel decompression is no exception. The skin incision is placed along the Langer skin tension lines at the posterior aspect of the medial malleolus, directly above the course of the tibial nerve. The tibial nerve is visualized under loop magnification. Now the retractor blade is introduced in the plane below the venous arcade and above the transverse tarsal ligament to gain the aerial view of the ligament compressing the nerve and the nerve proper. The transverse ligament is split along the course of the tibial nerve. The same manipulation is repeated proximally. The endoscopic tarsal tunnel decompression might be deemed a bit tricky for the unpracticed surgeon, owing to the venous arcade that most frequently covers the transverse tarsal ligament. However, if care is taken to introduce the blunt retractor blade underneath this venous arcade, one would observe that the veins do not hinder endoscopic surgery. After decompression, a blunt Turnus dissector is introduced into the decompressed space to make sure that the release is indeed adequate. The skin is closed in layers and a consecutive bandage with light compression is applied. This minimally endoscopic technique for tarsal tunnel release has its major advantage especially in elderly people with concomitant wound healing risk factors, for example diabetes mellitus, venous varicosities, and associated microcirculation problems of the skin of the lower extremities, polyneuropathy, etc.